The last video focused on the positive properties of nitrous oxide, of which there's many. But what about the disadvantages? Successful inhalation sedation is reliant on calm, confident behaviour management, in addition to the anxiolytic effects of the nitrous oxide alone. It just doesn't work on its own. It's debatable whether this is really a disadvantage because we're so used to providing our patients with the sort of psychological support, behaviour management when we're treating them under local anaesthetic. It's expensive. The basic setup equipment costs are about £4,000. On top of that, you've got the running costs of refilling gas cylinders, as well as an annual maintenance programme. This is borne against the £13 that the NHS will pay as a fee for a treatment using inhalation sedation. And with this in mind, it's not hard to see why there isn't great uptake of inhalation sedation within high street general practice. Both the setup and the running costs are considerably higher than that of intravenous sedation as well. Despite being a massive fan of nitrous oxide for treating medically compromised patients and anxious patients, one of my biggest issues with it is its environmental effects. Nitrous oxide is a greenhouse gas. It warms the atmosphere at 300 times the rate that carbon dioxide does. It also hangs around in the atmosphere for 100 years. Also, it depletes the ozone layer, which means that there's more UV rays getting through and more chance of people getting skin cancer, much like carbofluorocarbons, CFCs, which were outlawed in the early 1990s. So with this in mind, dentistry as a profession, we have to limit our use of nitrous oxide to exactly and specifically where it's necessary until such a time that there's a technology that captures the nitrous oxide used from the scavenged gases and prevents it getting into the atmosphere and causing these really devastating environmental effects. Some clinicians consider the lack of potency of nitrous oxide to be at disadvantages as well as an advantage, but we know it's one of these features that means it's so safe. But it's undoubted that intravenous midazolam does provide just a deeper level of sedation, which is appropriate to certain patients as well as certain procedures. The abuse of nitrous oxide is skyrocketing. In the 2014 Global Drug Survey, 39% of the UK respondents had used nitrous oxide in the previous year, and it was the 8th most commonly abused drug in the country. But this is much more common in the sort of early 20s and teenage age groups, more so than other drugs. Recreational users tend to buy it over the internet, where it's sold in these metallic, silvery cartridges. They're approximately 10 ml volume, and that dispenses into a balloon, fills up to 4 litres, and so very commonly sold outside the club or in festivals for anyone to have. And it is outlawed in the psychoactive substances legislation of 2016, but this seems to have done very little to curb its usage. Because of its very high usage within the community population, we're also seeing increases in the effects of chronic overconsumption and overexposure from the community setting. And that brings me on to my final point. Nitrous oxide can be harmful to anybody who's exposed to it regularly. It could be somebody who's abusing it, but if systems aren't appropriate and in place, then a dentist, a dental nurse, or anyone who works in dental surgery could be at risk of the chronic effects of nitrous oxide. These have been demonstrated in animal studies in significant numbers, but it's undoubted that people will have been exposed to what we now consider to be dangerously high levels of nitrous oxide in an occupational context and probably will have suffered some of these effects. However, now we have made ways of combating them. The significant negative effects of chronic nitrous oxide exposure occur mostly due to deactivation of vitamin B12. Vitamin B12 has a variety of functions within the body. One of the earliest hematological manifestations is that of a macrocytic anemia, which would more commonly be seen in a dietary deficiency of B12. With severe overdosing, this can progress to bone marrow failure, agranulocytosis, thrombocytopenia, and aplastic anemia. As discussed in relation to methotrexate, nitrous oxide exposure will impair the function of the enzyme methionine synthase, which is essential for neural growth and functioning. This means that chronic overexposure can cause peripheral neuropathies and a loss of reflexes. Initially, progress to more severe movement disorders, which can be confused for conditions like Guillain-Barré syndrome. B12 functions in the folate cycle, which is necessary for the synthesis of neurotransmitters such as serotonin and dopamine. So a B12 deficiency can then lead to what's known as a megaloblastic madness, which is a psychotic illness stemming from nitrous oxide overexposure. With all this interference in DNA synthesis and neuronal growth, it's unsurprising that nitrous oxide is to be avoided in the first trimester of pregnancy. Chronic exposure does have the potential for spontaneous abortion and reduction in fertility as well. Concerning regarding this occupational exposure first began in the 1960s with some studies demonstrating a reduced level of fertility of staff working in an operating theatre. These studies were methodologically flawed and certainly not representative of the levels of nitrous oxide exposure we'd come into contact with in dental practice, providing we're working safely. The data on toxicity of nitrous oxide exposure in a medical setting, despite its flaws, prompted investigation and legislation for those working with nitrous oxide to protect their health. One crucial piece of research concerned an early indicator of the suppression of the enzyme methionine synthase, and that found that for those who were exposed under a level of 1,800 parts per million, there was no suppression of this enzyme. The Health and Safety Executive used this piece of information and decided upon laws to protect staff. Nitrous oxide, along with over 500 other potentially harmful chemicals, is considered under the COSH regulations. The care of substances harmful to health legislation are general requirements imposed on employers to protect employees and other people who might be at risk of hazardous substances. This is done principally by way of risk assessment, use of measures to control exposure, the monitoring of exposure, and as well as there are duties upon employees to protect themselves as well. A nitrous oxide level of 100 parts per million was decided by the Health and Safety Executive to be the limit at which staff working should be exposed over the period of an 8-hour day. So that's why we say the maximum exposure limit is 100 parts per million nitrous oxide over an 8-hour time-weighted average. What does that mean? That means even if you're working for just a morning session in using inhalation sedation, then your exposure should be considered to make it comparable in relation to an 8-hour standard working day. Despite being based on the same data, a number of other countries have different safe working exposure limits. So in America, that can be as low as 25 parts per million. And other countries have a different measurement window depending on the peak exposure or over a shorter time period. It's important to bear in mind that this 100 parts per million is significantly less than the 1800 parts per million, which has been identified at a level at which methionine synthase starts to become affected and people start to have the effects of chronic exposure. In order to minimise the risks of chronic nitrous oxide exposure, we need to use a system that's compatible with active scavenging. What is active scavenging? Well, it's a system that removes or sucks away nitrous oxide from the surgery and from the patient and transports it out into the environment. It relies on a system that has a double layer mask, where the inner mask, which is shown in green in this example, forms a close but comfortable seal against the patient's face. The inner mask receives the gas mixture from the mixer head via an inlet on either side. There is a valve on the front of this mask called a flapper or flutter valve. As the patient inhales, the valve is closed, so only gas that the patient gets is that coming down the fresh gas tubing. When the patient breathes out, pressure increases and this valve opens, and the exhaled gas mixture escapes the inner mask into the outer mask. The outer mask here is coloured grey and is connected to the scavenge unit. So this exhaled gas mixture gets pulled away from the patient. The outer mask is not designed to fit snugly against the patient's face. In fact, it's got gaps around it, which means it can remove trace gases from their vicinity. This can be useful if a patient has decided to start talking to you, because they'll be breathing in the nitrous oxide through the nose and then it'll be escaping into the environment around us. And so we want to try and minimise the dentist's exposure to this. We want to minimise this by stopping the patient from talking too much. Room ventilation is also important to try and minimise our occupational exposure. The active part of an active scavenging system is essentially a pump that just sucks away gas at a 45 litre per minute rate, which can either be the form of a wall outlet or one of these mini scav units. Traditionally, opening a window was felt to be really helpful in minimising chronic nitrous oxide exposure and the risks of that, or by having a fan running. These can be a bit variable, and so generally speaking, room ventilation in the form of mechanical air extraction with a guaranteed number of air exchanges per minute is preferable. But a well ventilated room and an active scavenging system are not enough alone to keep you below that 100 parts per million exposure limit. What you need to do is have the appropriate technique and use the equipment in the right way. Exposure minimisation begins by selecting the most appropriate inner mask size to fit your patient, spending the time to get this comfortable and informing the patient what you're looking out for, what you want to minimise, i.e. drafts that form an escaping gas around the philtrum area above the top lip or around the bridge of the nose. And it quite commonly can happen during a treatment session where the hoses just drop down a little bit, as you can see here, and then it lifts up the nasal hood and creates a little bit of a gap above their top lip. If a patient is mouth breathing, they won't get any of the nitrous oxide, and the flapper valve should open and suck this away. So, we don't want mouth breathing because it's useless as far as sedation goes, and you will be getting some environmental exposure. But talking is much, much worse. Talking means that the patient probably is going to breathe in through their nose and then answer, if they're answering your questions, then you're just going to be getting that nitrous oxide and the active scavenging isn't going to work. So really try to minimise this. Rubber dam has been shown to be quite helpful because patients really have to nose breathe when that's in situ. Another part of good conscious sedation practice, which will minimise your risks of reaching the 100 parts per million limit, is by using only the concentration of drug you need to for as long as you need to. We talked about nitrous oxide variable duration of action. If you can turn it down, if the patient only needs it for the local anaesthetic, then just use it for the local anaesthetic. Or if they find that the most anxiety-inducing part, you can always turn it down afterwards. And that's really useful for empowering their sense of control in the procedure too. But we only want to use the concentration of drug that's titrated and the minimum level of sedation possible, because it's safer for them as well as safer for us. The rotation of staff also makes a difference. So what that means is that no one's job should be to provide inhalation sedation all day, every day, because they're much more likely to reach that 100 parts per million exposure limit than if they only do a session or two a week. Monitoring of nitrous oxide exposure is mandated by COSH. This can either be done using electronic devices that have real-time sampling, or diffusion tubes that you send off to the lab and they give you that 8-hour time weighted average after a few weeks. The BDA has documented a case in Belfast where occupational health were asked to monitor the occupational exposure within a clinic due to a staff member's concerns about their fertility, and it was found that the 100 parts per million level was exceeded. Obviously no causality can be shown here, but what was found to be the case was poor operator technique that was resulting in the environmental exposure to staff. Sedation was shut down in that clinic until such a time that people had been shown the right way of providing sedation. This is a vacuum control block which attaches to your scavenging unit or your scavenging wall outlet, and it is designed to ensure that you get that 45 litres a minute scavenging power. You control it to ensure that the ball bearing is within the green band by using this rotating feature here.